Well, we would like to welcome all of you to our High Performer TMIT webinar today. We are very, very pleased to be looking at the issue of aligning expectations and standards in infection control. We have a fabulous leader from the CDC and a great reactor panel that has joined us, and we're just absolutely delighted to be able to address this need, which we discovered and have been polling our audience about over the last few months, and we understand that this is a very, very important area. My role is really just to invite you to make sure that you have your audio turned up all the way on your computers. And if you are still having great difficulty after you've turned the audio up on your computers, go to the lower left-hand corner of your screen and you'll see a telephone icon. And click on that icon so that we can give you a line. Those of you that don't have the slides yet and would like to download those, go to our website, www.safetyleaders, all one word, .org. And if you click on the right upper quadrant, you'll see where our webinars are, and you'll be able to then download the slides for March 20th. And be able to then follow up and be able to listen to the webinar and look at the slides at a future date. I'm on slide 6 for those that have the slides, and just remind you we're on Twitter and Facebook, and remind you about SpeakerLink, our free portal that allows speakers and seekers of those who would like to speak at hospitals from the patient advocacy community and patient consumer advocates and leaders and speakers to go there. Our calling or mission is to save lives, save money, and create value in the communities we serve. We think that the issue of HAIs, healthcare-associated infections, is critical. I won't read our disclosure statement, but it's continually updated, and it addresses everyone on this webinar. And want to remind you that no funder or educational grantor has had any influence or direct contact with the speakers on these subjects. And what we'd like to do now is turn to Arlene Salamandra, who will give us just set us off with an inspirational focus on patients. We try to do that at the beginning and the end of every one of our webinars. Arlene is a terrific champion of patient safety. We've worked with Arlene for years and years. She's a published author in the patient safety literature and peer review articles regarding communication. She's also was a contributor and co-author of the chapter in the National Quality Forum, Safe Practices, that address engagement of patients and families, and has had continued input there. Of note, she's also been a caregiver in nursing homes and has been a great contributor and continues to contribute to helping defend caregivers and staff from the things that can happen to them in those communities. Arlene, would you please open us?
Well, first I'd like to thank everyone for being here on the webinar today. As all of us, and especially patients, we're all concerned about infections. And more and more we hear about it on the news from other patients, the experiences they had, and it's a big concern. We need to be more aware of infection prevention and work in partnership with our healthcare providers, not to be intimidated by them, and to make sure that washing hands, as simple as that, is being done when they see us. This ensures a safe environment for our care. So it's a team effort, so I'm glad to be here today. I'm looking forward to the presentation and what we could all learn about how to keep our families safe and give patients the best chance for survival. So thank you very much for being here. Back to you, Chuck.
Great. And I'm watching our comment section. For those of you that are having audio problems, please click in your lower left-hand corner of your screen to request a phone line if you're having problems. So we have a wonderful lineup here. We've got Joe Pers from the Centers for Disease Control and Prevention from CDC, and he will be our main speaker today, and longtime great collaborator and an infectious disease doctor, as well as one of our world's leaders in patient safety and medication management, co-development of the flight simulator that is used to test the safety of hospitals, and a wonderful contributor to the global literature, Dr. David Klassen. We just heard from Arlene, and we'll also have Mary Foley, former president of the ANA, as a nurse educator, who's earned her PhD and is a wonderful contributor and collaborator with us over time. So these are your speakers and panelists. What I want to do is just introduce some of the messages and let you know what you were telling us. In our anonymous polling, we asked the questions in the last 2 or 3 webinars of you and polled you, and we got a great distribution, and we want to remind you we're polling you today. But we asked the question, healthcare-associated infections are of growing concern to me. And we gave you a scale of 1 to 10, where 10 is very strongly agree, a 1 is very strongly disagree, and then you array your choices from there, and we develop a net promoter score. And we were shocked to find, even though there's so much focus on infections, 56% of our audience, and we had about 30% of you on our last webinar, and we had 550 attendees, so that's maybe 2 or 3 times that amount of people, because we know multiple people watch our webinars from institutions. 56% gave it a 10, and you see the rest of the distribution, which I won't read to you, but an enormous issue of growing concern. So the term was growing concern. The second question is, we need more practical know-how to address outpatient HAIs. Another 56% and 15% of you gave it a 9, which really is another enormous number. And then the last slide I'll put up, we need practical know-how to manage a patient safety crisis. And I set this up by saying this could be an infection, it could be a widespread outbreak, or it could be some other patient safety crisis where the fog of war hits us immediately. We don't know what to do. We have legal issues. We're told by advisors not to say anything, and then we are faced with that dilemma, which I have personally experienced. So I can tell you that fog of war is a real crisis. And in this case, we had a 52% give it a 10, 17% 9, and you can see the rest of the distribution. So these are enormously important issues, and I think Joe will help share with us the fact that we've got that we're still seeing outbreaks of infections that really are a major crisis for a healthcare system because of systems issues and not just one individual. I also want to draw your attention to this article, Safe Use of Electronic Health Records and Health Information Technology Systems, published in the Journal of Patient Safety in December, with co-authors Dr. Klassen, Dr. Swinson from Mayo, one of the top leaders at Mayo, Dr. Henderson, top leader at Cleveland Clinic, Dr. Zeltner, the former health minister of Switzerland, the current envoy for one of the programs for WHO, and Dr. David Bates from the Brigham, because Dr. Klassen was a co-author there, and we really addressed these major issues over a long-term timeline and the investments in patient safety, including the NQF safe practices, which you see arrayed from 2003 through 2010, and the slide of the timeline of investment in those areas. Also, the Institute of Medicine reports and how they really have drawn our attention to these areas of breakdowns in patient safety and quality. So I'm on time now, having introduced you, and I want to now introduce Dr. Joe Pers, who is the prevention team leader for the Division of Healthcare Quality Promotion at CDC in Atlanta. He entered the field of public health after training as an engineer, so he applies, and in our dialogue with him over the last 4 or 5 months, his engineering perspective and also being a great communicator really helps us understand the systems issue. He was also an environmental scientist, so he got a doctorate in public health from Columbia. He served as an epidemic intelligence service officer with the Tennessee Department of Health and has been with the CDC for 11 years. He's guided dozens of outbreak investigations and special studies drawing the drawing attention to the needs for infection safety and basic infection control. And I know, Joe, we visited just before you went on about recent outbreaks that we're seeing in the press as well, and I know you'll share some of that with us. He's co-authored and authored more than 50 peer-reviewed journal articles and focused also on interagency collaboration to support healthcare departments and partnership efforts. Joe, thank you for sharing your time with us. We're looking forward to your presentation.
Well, thank you so much. Yeah, I am really happy to be here with you today. I'm really pleased to have been invited to join the webinar series this month. And it was very nice to see that there is strong interest for this topic, which I'll be presenting on, which talks about, as you can see, aligning expectations and standards for infection control and recognizing this as a challenge for healthcare consolidation. Let me just review briefly the learning objectives. I hope that you'll come away understanding better how adherence gaps related to safe injection practice, basic infection control practices have led to outbreaks and avoidable patient harms. I hope that you'll come away being able to identify some of the leading risks pertaining to healthcare-associated infections and patient safety when consolidating, pulling in different practices, clinics, et cetera, into a larger health system, and identify some tools and learn how to minimize some of the what I think are overlooked patient safety risks and potential liabilities in this context. A little orientation to CDC and our Division of Healthcare Quality Promotion. We are working in many ways to improve the safety of the healthcare system. I'm just going to highlight two here. The first and third bullets. One is publishing evidence-based guidelines that can prevent infections in the first place, and then investigating outbreaks, as Chuck alluded to, which many times means being sort of on the front, scouting, finding the next issue, the next threat, and sounding the alarm, and hopefully driving good prevention work in those areas. DHQP has many areas of focus across the healthcare safety range of issues, and obviously, primary among those includes preventing healthcare-associated infections, and as we said, identifying emerging threats and improving systems to respond to threats. This next slide is one that I like to sort of pull out from the archives occasionally. You can tell from the graphics that this is a slide that's been around, but I think the messages are still very true. We have felt for many, many years that patients deserve effective infection control wherever they receive health care. And as you'll see, outbreaks are a constant reminder of where there are gaps as far as that kind of effective infection control. Again, thinking about infection prevention across the continuum as it relates to integrated systems, well, again, the promise of consolidation, of healthcare integration, is improved quality of care and accountability. When we, just go to the dictionary, look up a definition of consolidation, it is simply the process of becoming solid. And I really like that image because patient safety, of course, must rest on a solid foundation. And it also helps us think about, leveling the playing field. In other words, a uniform standard of care so that acute care facilities, which have had much more of a traditional focus, many more resources for basic infection control, bringing that kind of awareness, bringing those kinds of resources ultimately to bear in all patient care settings. As I say, basic infection control and prevention is really a key element in terms of having a good foundation of safe patient care. So, outbreaks. Well, unfortunately, we can point to, and I have personally been involved in dozens of outbreaks over the last decade, since the turn of the century, involving errors in outpatient settings. These have involved a wide range of infections, and it's not just the identified infections. It's, as you'll see, that we often are recognizing when we don't meet the standard of care, we're triggering a duty to warn. So we have had to notify, at this point, well over 150,000 patients regarding unsafe practices that could have put them at risk, and advising them to seek things like hepatitis and HIV testing. Common themes emerge from the outbreaks, and again, I'll be walking through examples, and so you'll see this sort of illustrated and reinforced, but we encounter what I have in quotes as obvious breakdowns in standard procedures, obvious maybe to some of us in the field, maybe not to all the practitioners. In other words, look at that last bullet. We find that healthcare personnel were often not aware of their errors. In other words, they didn't understand that what they were doing routinely was in fact potentially very dangerous. So let me take a few slides to kind of paint a picture and sort of talk about the landscape of care. So as it relates to outpatient care, we see growth and we have concerns. Over 1 billion outpatient visits per year. That means that all of us are making on average on the order of 4 visits annually to physicians' offices. We're seeing increasingly complex procedures performed in outpatient care. I just saw an article in a trade journal for ambulatory surgical centers just yesterday, promotion of the idea of doing total hip replacement as an outpatient procedure in an ASC. And as you know, our U.S. population is aging, and it's increasingly vulnerable. An example of that would be the 1 million cancer patients who receive outpatient care annually. As we say, there's been an expansion of services, but not necessarily increases in and attention to infection control. Many independent outpatient facilities lack a written infection control policy. They lack written procedures. And across the board, it's almost universally true that we lack systematic surveillance to detect infections originating in outpatient settings. That's just beginning to start to change. But for the most part, what we're relying on then is error reporting, outbreak identification, that sort of thing. So this slide is just an illustration of what I just said in terms of that increase in outpatient care and the fact that much of this is occurring in settings that are currently subject to little oversight or regulation. And this next slide is my attempt at sort of illustrating this with a bit of a cartoon, if you will. So if everything inside the blue bubble represents ambulatory care settings, we would recognize that some of that ambulatory care is happening in facilities that are part of hospitals or hospital systems, and they may be more likely to be sort of in the center of the diagram, of the Venn diagram, because oversight can come in many forms, but I think 3 of the key are certification, licensing, and accreditation. Now, certification is really a construct that has to do with participating in CMS programs and receiving payment from CMS. And so, for example, hospitals in the U.S., nursing homes, dialysis clinics are all CMS certified. Many of them are also accredited. That's true for hospitals at least, not for nursing homes or dialysis. And they are licensed perhaps. But now if you just take the typical outpatient clinic, doctor's office, it is most likely falling sort of outside those ovals and outside of those kinds of mechanisms that I think healthcare consumers probably take for granted, that there is licensing, certification, or accreditation. And so something to keep in mind for facilities, healthcare systems that are in a process of acquiring new practices and actively growing and consolidating care within their system. So oversight, again, depends on these factors related to certification. Why is certification important? I think, for one, when a facility is certified, then we have minimum health and safety standards that we can point to that do include specifications around infection prevention and infection control. For the outpatient arena, essentially that's dialysis clinics and ambulatory surgery centers. That leaves out, a very wide range of other types of facilities. Accreditation is going to be uncommon for an outpatient facility unless it's already part of a hospital system. And again, we can maybe turn, see the other side of the coin. Maybe that's one of the positives, potentially, of a movement towards consolidation, is bringing these, previously independent facilities into a network where accreditation may be applied. But the reality for now is that the majority of outpatient settings, I would say, are operating only under the authority of a physician's medical license, perhaps with a business license, and those are not subject to routine survey or specified, nationally specified safety standards. So a couple of examples of what can go wrong. This is a picture of patients lined up in front of the Tulsa Health Department in Oklahoma. They are lined up because they have received letters advising them to seek hepatitis and HIV testing. Why were they advised of that? Well, they were patients of an oral surgery practice, which had operated independently, I understand, for upwards of 20 years. But the dental board paid a visit, as did the health department right behind them, in the context of an investigation involving a new report of a patient with acute hepatitis C. The on-site review very quickly identified an array of unsafe injection practices. Among the most concerning was the allegation that dental assistants had been trained by the surgeon to do things like start an IV and administer sedation. They also found, other issues with the way injections were prepared. Some of the additional examples, we'll unpack that a little bit more. There was also concern about equipment reprocessing and sterilization deficiencies. And in the end, this was confirmed as the first U.S. report of HCV transmission in a dental setting. And again, thousands and thousands of patients affected directly or indirectly as a result of this. And here's what is frankly a tragic example. This comes just from 2012, as did the dental example I just presented. Here we have a report of a woman who'd undergone a liposuction procedure in a cosmetic surgery center in Maryland, became infected with invasive group A strep infection, and died. She was one of 4 confirmed cases that the health department investigation revealed. This was a facility that is not subject, or was not in 2012, subject to licensure requirements in the state of Maryland. There were, as the investigators are quoted here, deviations from standard infection control practices that were evident in the clinic, and these included reports, for example, of expired medications, visibly dirty equipment, not having autoclave logs. In addition, the physician was not trained as a surgeon or board certified, and the facility was not, as I said, licensed or accredited or certified. Here is an example from yet another outbreak. This was related to infections stemming from joint injections. And the health department, as I'm showing this just to kind of show, how sort of far off we are from, what we would think of as our minimum expectations around safe care and around basic infection control. So you can see for yourself that, this was what the health department received back when it asked for a copy of the facility's infection control program. So, having investigated many an outbreak in the outpatient care setting, and realizing that we have effective, applicable guidance that's not reaching the intended recipients, we undertook the creation of a CDC guide to infection prevention in outpatient settings. This was developed in 2011, so not quite 3 years ago. May 2011 is when we first released this. What it is a summary of the existing guidance, of which there is, quite a bit of evidence-based guidance that's been generated by CDC with its Infection Control Practice Advisory Committee over the last 2 decades or so. And, realizing that the average busy outpatient provider can't realistically be expected to be familiar with all of that, we distilled it down to the essentials. And what you have is just in the space of just 15 pages, of really accessible text and tables and figures, our guide to infection prevention. This is something that I would really recommend to the webinar viewers to become familiar with if you aren't already. As I highlight, the information contained in the guide is based primarily upon elements of standard precautions. What is standard precautions? Well, standard precautions is a set of core measures defined by CDC and the Infection Control Practices Advisory Committee that really apply to all patient encounters, all patient settings. And some of the main topic areas that are included here are things like use of personal protective equipment, gloves, hand hygiene, injection safety, environmental cleaning, care of equipment, reprocessing, and so on. The basis for standard precautions is in our 2007 guideline, the executive summary of which I'm showing some excerpts here because it's worth maybe reminding everybody that, in the 2000s, it was already becoming clear that there was this transition of healthcare delivery to, among other things, ambulatory care, freestanding specialty care sites, long-term care, and that what was needed was a better uptake of standard precautions as the foundation for preventing infections in all healthcare settings. The 2007 guideline was where essentially a new element was introduced into standard precautions, and that was safe injection practices. And essentially these are a set of practices, some of which were so basic it was long felt that they, could go unstated, that everybody would, understand things like a syringe is a single-use item only to be used for one patient. Unfortunately, accumulating outbreak evidence by the mid-2000s told us that, in fact, it would be very important to highlight safe injection practice as part of standard precautions. So again, a set of measures for performing injections safely, and description of the appropriate use and handling practices around parenteral medications and related supplies. So with this, I'm going to spend the next section talking a bit more about injection safety, and I'm going to begin actually by illustrating a classic example of unsafe injection practice. And this is a diagram that was prepared in part to help illustrate the mechanism by which hepatitis C virus was transmitted in a Las Vegas, Nevada outbreak. This outbreak was identified by the local health department. We were fortunate that they picked up on 2 reports of acute hepatitis C. Remind yourselves that hepatitis C often manifests as a silent infection. So when we have identified patients with, for example, jaundice, seeking care, receiving a diagnosis, it's very important that they be reported to public health and that those cases get investigated. In this case, the health department had actually been staying tuned in with CDC reports and health department reports showing associations between hepatitis, new hepatitis infections, and endoscopy. They noted these patients both received care in an endoscopy clinic. It just so happened that this endoscopy clinic had pursued certification with CMS, so it was actually designated as an ambulatory surgical center, and yet it had not been identified as having unsafe practice as part of the survey process. The investigation confirmed HCV transmission. What happened was, and this is, I'll try to just talk you through this briefly, this involved reuse of syringes to access single-dose vials. So if you're starting on the left-hand side of the screen, you're beginning with a new vial, in this case the drug propofol, clean needle, clean syringe. Obtaining medication for a patient who's about to undergo a colonoscopy, administering to the patient. Now, of course, they don't know which patients have bloodborne viral infection. That is the whole point of standard precautions, is that you treat every patient the same. But this patient had a HCV infection that may not have even been known to the patient, let alone to the people working in the clinic. They, in the process of doing an injection, you have backflow. You have, you do not, you basically have hydrodynamically, you're having exchange with patient body fluids and the medications. That can result in contamination of the needle and syringe with viral particles. And you know, it would be okay if that's where the story stopped, right? We wouldn't be talking about an outbreak. But you know, here's where a series of error occurs. If you focus your attention on the red circle, the nurse anesthetists perhaps were under the impression that contamination would be limited only to the needle, so they were changing the needle, which in and of itself is a mistake. It's a medical error, I would say, because they are thereby exposing themselves to a risk of needle stick injury. They did this so that they could acquire some additional propofol for that patient, right? Sedation is something that has to be, for lack of a better word, tweaked over the course of a procedure. And they went back to the vial with a used syringe. So now you have the up arrow towards the right-hand side of the screen is indicating transfer now of viral particle from the syringe to the vial. And again, you know, if the story stopped there, we might not be talking about an outbreak, but they went a step further, and this clinic was routinely using single-dose propofol vials for multiple patients, and thereby propagating infection. And this process of reusing a syringe to get additional medication, not necessarily reusing the syringe for multiple patients, but to access and then contaminate a shared vial, you know, we think of in the vernacular as the double dip. So this double dip affected many thousands of patients. It was reported that this was the clinic's routine practice. There was some allegation that the managers of the clinic actually encouraged this reuse of syringes because since they were seeing 60 patients a day, you know, even though the savings were very small, that might accumulate. Again, that's what was alleged. And, you know, lo and behold, you know, we had a public health crisis in not just Las Vegas, but the state of Nevada. It really shook the foundations of trust, I would say, in the healthcare system. Here's another example on a different scale, but again, maybe worth noting that we have investigated many injection-related reports of meningitis. So we're talking about really severe infection, in this case not a virus, but a bacterial pathogen. There's some other examples involving contaminated compounded medications that involve fungal infection, and we'll touch on that later if time allows. But here, the point that I want to make is that, you know, this could have been prevented by following, you know, standard precautions. Standard precautions calls for wearing a surgical mask when performing this type of injection. The harm to multiple patients may have been prevented if they had not been reusing single-dose vials of contrast agent. And the final point I want to make here is that when our investigators talked to the radiology physician assistant who was performing these injections, the assistants indicated that they did wear masks to perform the same procedure when they worked in a hospital. So again, there's for whatever reasons, there's a sense that, risks are lower in the outpatient setting and we don't have to take all the same precautions, and that's a really dangerous misperception. One more example of what can go wrong on this slide, and now we have an example from a pediatrics clinic in the state of Colorado, where a medical assistant was administering flu vaccine to very young children. And we can infer that this person had inadequate training and perhaps inadequate monitoring or oversight, by more highly trained staff in the clinic. And this assistant reportedly was under the impression that the pre-filled syringes of flu vaccine that they had available in the office were adult formulation, which would have twice the dose that a young child would need. So they would actually reserve the remaining vaccine and administer it to patients who came in subsequently. Fortunately, this only affected several dozen patients, but you can imagine this, this caused severe anxiety, heartache for the families involved, and I believe for the provider group as well. So again, seeing the need for more effective implementation of basic infection control, we have at CDC developed a checklist to accompany the summary guide for outpatient settings. And this checklist runs about 12 pages. I'm going to show you some excerpts from it in a minute. I just want to remind again that this is based primarily on standard precautions, so it's nothing new. And what we hope that the checklist can be used for at individual facilities, but really increasingly across health systems, is to ensure that each component of that system has appropriate infection prevention policies, procedures, and supplies for the provision of safe care. And we would, I think, all benefit from systematic assessment of adherence to correct practices. So regular audits to complement regular training. Just going to give you a couple of snapshot views. As I said, the actual checklist section runs about 12 pages, but you can see there's a lot of white space in this document. So, in the end, we're not talking about thousands of elements that need to be reviewed. And this can be tailored, of course, for the individual practice setting. One activity that applies really across the board, any practice setting, is hand hygiene, which Arlene highlighted the importance of at the very beginning of the webinar today. PPE, things like glove use, for example, and high-level disinfection of reusable instruments and devices. Also a section on sterilization, thinking back to some of the examples that I provided earlier in terms of the oral surgeon or the cosmetic surgery practice. You can see how applicable this is. And then in the January webinar, as part of the TMIT series, we had Cleveland Clinic representatives talking about their best practices to inform uniform best approaches for things like endoscope reprocessing across the healthcare system. So this is all very important, and you'll find appropriate content in our CDC checklist for outpatient settings. Here's a little snapshot. There's actually, there are two main sections in the checklist document. The first really applies sort of at on the administrative side, and that's what you see here. This is the section for safe injection practice, talking about things like medication purchasing decisions, reflecting selection of vial size that meet the needs for the actual procedures being performed, providing an environment that's conducive to safe injection preparation and delivery. And then the third item is something that we're going to touch on at the very end when I'm going to run through some emerging issues. And that has to do with access to controlled substances to prevent narcotics theft and diversion, to be thinking about that as well in the context of infection control and injection safety. So this was sort of the admin side, and you can see it's not just the checklist items highlighted in white. There's also embedded and integrated in this document guidance and reference materials, like our frequently asked questions and training video and so on. So then here's the section where one would actually observe care and determine whether, in fact, needles and syringes are used only for one patient. And you can read the other examples yourself. One that I'll highlight, again, relates to single patient use of things like intravenous solution bags and single-dose vials. One reason I'm highlighting that is because this has been a problem area. We have identified, again, dozens of outbreaks in which reuse of single-dose vials was a common factor. And the MMWR that we published here last, I believe this was published in May of 2013, this highlighted two outbreaks. One occurred in Arizona in an independent pain clinic. The other occurred in Delaware, and my understanding that was a hospital-affiliated orthopedics clinic. So one can imagine that might be a clinic that would sort of fall, into the realm of a hospital system. It is a clinic that may have been, may have been spun off, or it may have been acquired. But at any rate, one thing that we note in the full report, which I encourage you to read, is that that clinic did ultimately benefit from having access to the resources of the hospital system's infection control department in terms of implementing improvements, remedies, and corrections. These were serious infections. In the Arizona outbreak, 4 patients received injections from a vial that had been created by taking a 50-50 combination of contrast agent, which is used to visualize the placement of the needle for paraspinal injection, and saline. For reasons that we don't fully understand, the physician was diluting that contrast agent, and he created basically his own compounded, diluted 10-milliliter vial of saline plus contrast. All the 4 patients who received that injections from that vial later that afternoon had very severe outcomes. One patient was hospitalized for 41 days and then required transfer to long-term acute care. And chillingly, the 4th patient was actually found dead in their home. So again,
wow.
Yeah, sorry, it's an eye-opener, I would say. When you're in a position to sort of be on the front line investigating these, to just understand how severe the impacts are, and how a cavalier approach to patient safety and infection control can have an absolutely devastating outcome. But again, I think we always want to focus on the positive, right? We're trying to learn from our mistakes in the healthcare industry, as we would in any other industry. And so seeing the positive, these are opportunities to educate our U.S. medical community at large, right? That's why we're documenting these in peer-reviewed publications, MMWR articles, and increasingly in our educational materials. And so I have a screenshot for you of one of those materials. I'm going to actually ask you to sort of be patient with me. This was developed as an infographic, so it's better to experience it that way. I'm not going to take a lot of time with it, but I do have a couple of panels that I'm just going to step through right here. And so this is just an example of the type of material that we've developed in our One and Only campaign. Here's something that's directed for the actual provider to help them from their perspective to understand the basics around providing safe injections. And then here's another version of that where preparation and delivery of safe injection is represented as a series of steps. I think very important perhaps for the type of audience that this webinar series creates is this perspective, that of the manager. On the lower right side, things like, are you purchasing the safest available medication? Do you arrange infection control training for your healthcare personnel? And then, of course, patient perspective. It's not the patient's responsibility to make sure that they're receiving safe care, as it pertains to infection control or any other dimension of healthcare delivery, but they can be very valuable partners in improving safety, as we all know. And so, patients may wish to consider questions, that maybe begin with but don't end with, did you wash your hands? But asking about, whether the injection one is about to receive, is in fact safe. Just asking for some reassurance of that is a good signal to the provider community, we believe. And so that this tool actually ends with this panel, which I think is my favorite, which is this reminder that at the end of the day, we are all patients. We should, again, think about standard precautions. That means that we do right by every patient. We don't, use a single-dose vial just for one patient if it's our family member, or if we know that the patient upstream, had some communicable disease, right? We need to do it for every patient every time. And in the next section, I would just like to briefly sort of review that, risks to cancer patients, are particularly concerning. As we said, we need to do right by all patients, and I think in particular cancer patients, of which, as we say, there are 1 million, U.S. residents receiving this type of care each year, need to be protected from preventable harm that might manifest as a serious infection. You can see this long list. This is 9 outbreaks. And again, knowing that we don't have a good system to detect these, this is very concerning to us at CDC, and I know to all of you. What we have seen in those outbreaks kind of mirrors what we've seen in, other outbreaks that I've described here or that, you may be familiar with. And so unsafe injection practices were predominant in that series of outbreaks, as well as things like poor hand hygiene and then, things that are related to more specialized care that a cancer patient might receive, for example, as related to accessing central lines. And, this is just the most recent example. In the interest of time, I won't dwell on it, but would point out that this was just published this month, and it describes an outbreak of rare bloodstream infections in patients of an independent oncology clinic in West Virginia, which is located inside a hospital complex, so integrated but not integrated. And we find this in many situations where a patient, may be coming to the hospital complex, visiting a clinic that is renting space but doesn't have formal ties that are extensive. In this case, the clinic was using the hospital lab, and it's thanks to that relationship that this outbreak was detected, because it was the hospital lab that noted an unusual increase in bloodstream infections with this unusual species, noted that they were all being requested through this clinic. Among the things that our state and CDC investigators found was that they were preparing chemotherapy in a hood, but this hood was not in a space that meets the pharmacy standards that should apply, and in fact it was located adjacent to a window. And you can see some of the other findings there. Again, severe clinical impacts. So we have gone, one better in terms of the outpatient guide and the outpatient checklist. Here is our model infection control plan for outpatient oncology settings. I wish that we had the resources and ability to develop similar model plans for all settings, but what we have to offer, I think, is significant in terms of this model plan for outpatient oncology. And I know just from reading, the Atlanta papers that cancer clinics are increasingly being included as part of consolidation efforts, at least in the Atlanta area. And again, there's a promise of improved quality that comes with that, which I believe includes more uniform infection control. Just briefly, the intent of this document, and again, this is all available online, for any of the webinar viewers to please make use of, is just to offer a plan first for facilities who don't already have a plan, and then for facilities that do have existing infection control plans, to make sure that to look for areas for improvement by referencing this plan. And the main components of the plan, again, are going to look familiar. They're going to reference back very heavily to the content from the outpatient guide, standard precautions, and additional elements pertaining to surveillance, education, and so on. I'm going to apologize if I'm wearing anybody out. I do have a few more slides. I figured I had to make the most of this opportunity with you today. So.
Oh, please do, John.
Okay.
Typically, we have more than one speaker, but we were so honored to have you, and you're really sharing some vital information as our organizations are consolidating, and they're really adding physicians' offices and outpatient facility labs, and so really take your time. You got plenty of time. So
okay. Well, thank you. Thank you, Chuck. I really appreciate it, and it was nice to hear that I was given extra time today. So I'm just hoping I haven't taken over advantage of it. But anyway, I really didn't want to leave the audience without touching on just a couple more topics which pertain to insulin pens, compounded medications, and drug diversion, and then we'll wrap up with a little bit more review of some CDC educational materials and close it out. So insulin pens are devices that are designed to provide insulin for an individual patient, but can provide more than one dose, and they were really designed and are well suited, for the convenience of the individual patient in their daily lives, managing their diabetes. When these devices are introduced into hospitals and healthcare settings, they really have to be treated with great care, because essentially, all we have here, referring back to this figure, is, a packaging for a needle and a syringe. So in this case, the insulin pen is designed where the needle can be changed out. So we've had providers think that, oh, if I change the needle, now I can use it for more than one patient. But again, that's just a form of direct syringe reuse between patients. And so while we haven't established outbreaks in terms of infection transmission, many facilities feel like this is triggering a duty to warn. And so the headlines from the previous slide really are, just from last week's newspapers that involved a facility, again, in New York. And I do want to highlight, something that I see as a real positive. The VA Medical Center often has been sort of in the news, doing patient notification related to errors that they've identified in some part of their system. I don't believe that errors occur more or less often in the VA system, but I do believe that they're holding themselves to a very high bar in terms of transparency. And so here's an example of the Veterans Health Administration capitalizing on one of their recent events, as summarized on the previous slide, to make sure that there would be system-wide improvement. And so in this case, they have designated move away from the use of insulin pens in their facilities. And what we can offer, one of the tools here is, this is an example of a poster that our One and Only campaign has generated, which is a reminder that these are single-use, single-patient devices. And there's there is an accompanying brochure that can help with provider education if that's something that's desired. Moving on to one more of sort of the emerging topics. This has to do with compounded medications. Many of you are familiar with the NECC investigation, which resulted in hundreds of cases of fungal meningitis and other infections. Here is a recent summary from February of this year of an investigation that CDC and health departments performed in 2012. And won't go into detail, but this publication is available for free online. Emerging Infectious Diseases is an open access CDC journal. And one of the takeaways is that many outpatient facilities were and are obtaining medications from compounding facilities that are distributing across state lines. And it's important, as the authors of this paper point out, that practitioners are aware that compounded drugs are not the same as generic drugs, which are approved by FDA. These drugs are not, manufactured under the same protocols and under the same framework. That is beginning to change. In fact, there's a meeting that FDA is hosting today, and I'll be joining tomorrow to talk about implementation of the new compounding safety legislation. But as pointed out in a January letter from the FDA commissioner, you can play a role in improving the quality of compounded drugs by requiring compounding pharmacies that supply drugs to your facility to register as outsourcing facilities. And those of you who are more familiar with this will you recognize those as your new 503B type facilities. So it's an attempt to kind of move some of the mom and pop compounders out of this, large scale production, interstate distribution, absent prescriptions, and to put them into a lane where good manufacturing practice would apply.
So, Joe, when we do the Q&A, we'll want to talk about what source documents could our safety and quality folks get to their purchasing people, because we don't typically have the purchasers on this webinar. So a little help there,
sure,
so that they would have a site, a link, whatever. But just keep going, and you've got plenty of time. So,
well, thank you. Yeah, you're being very generous. Thank you. Another topic, and the breaking news headline, I think is appropriate. Not to dwell on this example too much, but this is the type of thing that we're increasingly hearing about, and it is physicians, but also nurses, technicians who are engaging in theft of prescription drugs, namely narcotics. And, that can take many forms. There is, of course, in our society as a whole, an epidemic emerging regarding prescription drug abuse. But this is just one facet of it, but one that is really concerning for patient safety, because, if you're able to sort of skim along here, in this case, a doctor is caught removing syringes of propofol and fentanyl, and then, taking those for his own use. We've actually had outbreaks where those syringes were used and then put back into circulation after the contents were replaced with, for example, saline or water. And so, I believe that the outbreaks are helping to drive the awareness. So again, I wish that these events never occurred in the first place, but if they have to occur, then we have to learn from them.
And Joe, through the grapevine of our, we've got an enormous test bed of, over 3,000 hospitals, and 25,000 people are invited to our webinars. Many attend them later, and it depends on the topic. But we're hearing from them, a drumbeat that this is a growing problem of drug diversion is a hazard zone. We've recently undertaken a care mapping process, and it is one of the multi-causal agents in typical procedure labs. We have to add it to the checklist.
I agree. This is something that is really going to take a lot of concerted effort. And actually, to your point, Chuck, this slide, which highlights the work of both the Minnesota Department of Health and the Minnesota Hospital Association, may serve as a model for us. In this case, they were reacting to one of the outbreaks on the previous slide and brought together a coalition of various partners representing the hospital and provider community, law enforcement, healthcare licensing, and others, experts from the Mayo Clinic, and this is a report worth reviewing for listeners who are interested in the topic. I've also added 2 other references there that have information on this, and all I can say is that we hope to have more information to inform this discussion coming from CDC in coming months as well. One piece that we do have, tying it back again with our one and only campaign, is this bloodborne pathogens training activity, which is meant to complement the annual OSHA training that's required for many healthcare facilities. Many of the outpatient facilities, it may be the only form of infection control training that is administered on an annual basis. And what we're trying to do here is to insert the patient protection piece. But you might find it interesting that diversion is also addressed in this context. Again, it would take maybe a lot more time than we have today, and maybe in the future we could talk more about sort of the risk to providers and risk to patients related to diversion. But this is an educational activity that we highly recommend facilities think about incorporating to sort of freshen up the annual bloodborne pathogen training. It's basically a narrated, interactive 20-minute activity. And so as I begin to wind up, I'd like to go over this slide as a reminder. I mean, we might think that it can't happen to us, or we would like to think that our own facility or system is immune to these kinds of problems that I have described. But I can tell you that when we've done surveys of doctors, nurses across the U.S., we find a very stubborn and consistent adherence gap. Again, using that term politely, adherence gap of, in this case, 1%, who admitted that they sometimes or always reuse a syringe on a second patient. And 1%, at first blush doesn't sound so bad. It means 99% at least say that they're doing the right thing. But 1% times hundreds, in some cases thousands of personnel connected to one facility or system means that there may be a significant problem sort of lurking in the shadows, if you will. And then the other 1% statistic there actually is illustrating what we described earlier as the double dipping, where you would reuse a syringe not for multiple patients but to access a shared vial. And then the last statistic pertains to single-dose vials, and I actually believe that 6% is an underestimate. I think that many providers often don't really distinguish single-dose from multi-dose vial. If the vial is big, they think of it as a multi-dose vial. We encounter this all the time with agents like propofol and contrast agent, which are not actually available in U.S. market as multi-dose vials and yet are often referred to as such. So again, as we sort of wind it up here, encourage viewers to visit the One and Only campaign website, where all of our materials are free for download or for order. Again, a real nice wide array of materials, as you can see here. They include a one-page checklist, which is derived verbatim from the outpatient guide and checklist. A video, which has been very well received and won several awards and only takes 4 minutes of your staff's time or your own time to review. And again, we have our checklist. We have the outpatient oncology infection control plan available to you for download, and encourage their use. And so by way of sort of summary and takeaway, I really would encourage health systems to assess whether all components are consistent in terms of their approach to basic infection control, with special emphasis on the items and activities listed on this page. A reminder that we have resources available to support your efforts, and in fact are very interested in hearing about your efforts. One way you can do that is by connecting with us and our one and only campaign. We actively seek new members to sort of pledge and sign on to the campaign mission. And so I guess with that, I'll pause and turn it back to you, Chuck, and to the other speakers.
Well, fantastic, Joe. That was absolutely terrific, and I'd like to draw the attention of the audience to the right lower hand corner of your screen, and put your questions in for Joe. Drop them in there, and we'll go ahead and ask them. Is my first question, and then we'll go to Mary Foley after that. My first question, Joe, is in the evidence-based literature, what would be the most recent article, or is there a review article on the outbreaks and lessons learned, kind of a compendium of, or a timeline of many outbreaks with lessons learned, so that it could be a one-stop shop to read?
We have attempted that sort of thing periodically. I feel like we're due for another go at that, but right now there are several. I know not everybody reads the Clinics of Liver Diseases, but we did, I think, a very nice review of unsafe injection practice and breakdowns in basic infection control leading to viral hepatitis transmission in U.S. healthcare settings. There's an article in Annals from a couple of years ago that reviewed outbreaks of, again, viral hepatitis in outpatient settings. We have a nice article in the journal Medical Care, which I believe that article is currently open access, that summarized all of the outbreaks and patient notification activity in the United States related to unsafe injection practice between 2001 and 2011. And I may be forgetting others, but we would be happy to, put a little package together if that would benefit.
Joe, that would be terrific, because I think we have a lot of educators on the webinar, and if we had one place to go for a package, I could see them doing having a noon program or a breakfast program on this, especially because most of the centers around the country are in this consolidation mode and adding new organizations, the outpatient organizations that neither would be accredited, nor. And I think your slide was great that addressed accreditation and licensure and certification, because there are that is a big problem that we hear here as an issue. I'd like to just, and we've got plenty of time for Q&A here, I'd like to turn to Mary Foley, who has just been an absolute terrific champion for patient safety. She's the director of the Center for Nursing Research and Innovation at the University of California in San Francisco. She has been a long-time patient champion who's had an event in her own family that really energized her passion. She's worked with the center as associate director since 2004, has many accolades. She was the former president of the American Nursing Association and RN for more than 35 years. continues to write and lecture all the time. She has been a wonderful contributor to the NQF Safe Practices. She's been published with Arlene and other patient advocates as well, and I think is a terrific champion. Mary, you may have other comments or questions, but as a nurse, and as I listen to this, there's so much that is direct nursing care, nursing education, and reemphasis of a lot of the issues that pertain to nursing and patient safety. Do you want to maybe comment on whatever you want to regarding Joe, but then secondly address that? Mary, are you on mute?
Hang on one second. I have to unmute her.
Okay. Thank you, Kyle. Sorry for the delay. Joe, it really does seem to me that there so much of what you shared with us are fundamentals that we can apply to the outpatient environment, where we've just gotten lax and had what we would call migration of boundaries and normalization of deviance. Is that a fair statement, where even though we might be well trained, we've just gotten more and more relaxed in that environment?
I think that that's part of it. I think that, at least anecdotally, right, we see, and I provided you that one example from the radiology clinic where, you know, they were consciously applying a different standard depending on whether they were operating in, you know, an acute care environment or an outpatient setting. You know, likewise, we see a lot of, you know, delegation and potential issues in terms of nursing scope of practice. So I think, you know, a lot of caution flags are being thrown here in terms of, you know, very careful review of what's being delegated, the training that's being provided to, you know, all the staff involved in providing care, and monitoring safe care practices.
Great,
all very
great.
important.
Kyle, is Mary on?
Hi, good morning, Chuck.
Mary, did you hear my question? My comment was that there's an enormous amount of nursing fundamentals and education in the areas where there are the breakdowns, and then other thoughts that you might have to question or comment on Joe's wonderful presentation.
Yeah, thank you, Chuck. Good morning, and thank you, Joe, for a great presentation. It's an honor to be part of this panel and part of the TMIT family. I have a lot of responses. There's both personal and professional. Let me start with the lapse that occurs when, and I thought it was striking, the difference in practice when it's an inpatient versus outpatient. And many times they are our same patients. You know, it depends on where their appointment is or where they are in the transition of care. And I think of an oncology patient particularly. It's shocking that the information that we've, you know, learned from our very first day of practice about prevention and precautions and infection control can be almost forgotten or just not applied consistently across the settings. I think one of the areas that I've been most troubled by is, you know, I know the oncology story, and my colleague Evelyn McKnight, I know, is online. I saw her name appear, and, you know, I work with her, and the Honor Reform campaign is so important to remind us that these lapses in practice affect people's lives directly. It isn't about saving money, and it shouldn't be about, you know, let's be cost effective and reuse that IV bag or that vial of propofol over again, and where folks forget that, you know, everything they've learned, because there may be a financial incentive or somebody tells them it's okay. You know, when a medical director says to the staff, oh no, it's okay in our practice to reaccess that bag multiple times, where in the world did the scientific mind go? And I, you know, I wonder in the outpatient and ambulatory setting, private doctors' offices, dental offices, you know, with much less oversight and management and leadership presence, is that what we're seeing here? Are those breakdowns the result of authority not translated into those settings, or those who are in authority having either flawed thinking or perhaps perverse incentives? So, I think this is a wonderful subject, and the science between, inpatient and outpatient practices and the breakdowns deserves more attention, and clearly opportunities for us to be instructive, because so much of our care will be non-hospital, as we know over and over again. I shudder to think what the home setting looks like if established outpatient settings have so many acknowledged lapses, and we know people don't admit everything that they do, and they don't report every mistake that they make. So I think it's a very important topic. Joe did a fabulous job, just really documenting the nationwide implications of this. And I know attaching it to the reuse and drug diversion is a very important and timely subject, because we know we don't want impaired practitioners, and we don't want the cross-contamination that occurs. So raising the awareness and helping institutions recognize those practices, and when there may be breaches in infection practices, what it might imply, and it could imply an impaired practitioner. Very important topics. I see an incredible alignment. I work as well in patient safety and in occupational safety, and I've been an advocate for bloodborne pathogen controls for workers for many years, and that's where my work with the honor reform has come. And I see an incredible alignment, that the devices and the procedures that would protect the healthcare worker will also very likely protect the patient from reuse or reaccessing. So we need to look at single-use, auto-destruct, all of those principles of engineering that can be built into our devices or our vials. We need to do a better job at not letting human beings who can be flawed or just not smart enough to not do something careless, not let them do it carelessly, or prevent the reuse or the reaccess. So I'd like to look at the manufacturers, not just the purchasers, Chuck, but look at the manufacturers to be partners in devising solutions so that you cannot reaccess, so that there is a permanent seal or a complete elimination of that product or that device from ever being able to be reaccessed. So I think that's an important consideration. And lastly, let me just say that the alignment of patient safety and worker safety is absolutely apparent in every one of these presentations, and today particularly because of the bloodborne pathogen work and the overlap of issues around needle stick and sharp injury reductions to workers, and then clearly, some of the patient and community risk that occurs when there are breaches in those principles. And from the Lucian Leap Institute to Occupational Safety and Health Administration, we're seeing the value of aligning those patient safety and worker safety practices and philosophies so that there is a safe climate for all. And I think that's a leadership imperative. And I know you've got infection control practitioners on the line, and you have managers on the line across departments. And when we can talk about safety for all and really look at, when you purchase something, is the worker as safe as the next patient will be, we'll raise the bar. And I think we need to raise the bar simultaneously and not incrementally and not one step at a time and not in a trade-off between either the patients or the workers. So wonderful program today. Thank you for allowing me to comment on it, and I'll sit back and listen to the response to the questions that I've seen coming in that look excellent. Thank you, Chuck.
Great. Thank you so much, Mary. We'll go to David Klassen in just a moment. But, Joe, what we do is pull this audience to really have them help us fine-tune what they need. So the first question, so go to the lower right-hand corner of your screen, if you would, audience, please. And then I'm going to come to the questions that are being asked, and then I'll go to Dave Klassen and then to Arlene. First question is, I have direct impact on driving adoption of innovations to reduce HAIs in my organization that will require more funding than we have budgeted. One of the dilemmas we hear is that a lot of our folks that are in our network, Joe, don't have direct impact on driving budgets. So we've got to go upstairs to the C-suite. So my guess is those of you that know we need to do something but just don't have impact on new budget items or an increase in the cost of a product or service or innovation or education, those of you that don't, even though you're passionate, you might give this a 1 if you very strongly disagree that you as an individual can't do it. Number 2 is if my organization became aware of an innovation to reduce HAIs, it would take more than 6 months to adopt it. We're hearing that it really, Joe, it takes time from awareness to really a new systematic change and adoption of a new innovation takes time. It takes much longer than just knowing we got a problem or an outbreak, and it takes many months and sometimes years to do it. And even when we do, if you look at McGlynn's article from RAND, that even when we have great evidence-based practices, we only adopt them less than 55% of the time, even if they're great evidence. So we really want to pull the audience to see, is it really as long as we think? The third question is, it is difficult to get operating room or procedure facility HAI innovations requiring increased cost adopted at my organization. Joe, we're all aware, but the problem is, again, the dollars and cents. And we want to see how big a problem it is. So if you have a problem getting new things into your organization because of cost, you directly in your position, that would be a 10 if that was the case. And then the final 2 questions are, it takes committee processes to adopt innovations that require more funding than we have budgeted. I think the days are gone where one strong-voiced doctor at a table can get a hospital to spend more money on a new product, service, technology, or education. It really requires committees, and if that's the case where you're really up against committees so we can equip you, please let us know about that. A 10 would be very strongly agree. A 1 would be very strongly disagree. And then the final question is, one staff person or physician alone cannot drive change in a service such as OR and outpatient procedure suites. And again, we're asking the same question in a little bit different way. Can one person do that in your organization? And we believe that Joe, is increasingly committees. It's getting bogged down, and we need to have tools to get your information in front of multiple people that are teams that have to make decisions. So we'd like to have you all answer these polling questions. I'm going to go to Dave Klassen, who has just been a master at teaching us about how the magnitude of under-reporting, the under-voluntary reporting of problems. And Dave, you've been the pioneer developer of the global trigger tool, an undaunted champion of the flight simulator to measure safety of CPOE, and you're an infectious disease doctor. Comments there, we've been talking about the outpatient environment and adherence to policies that we know are fundamentals, but that we've got maybe a much bigger iceberg under the water than we know of. Comments or thoughts, Dave?
Yeah, it is David Klassen. Chuck, thanks so much for including me. It's an honor to be here. We did a study with the AMA about 2 years ago where we looked at all the literature around ambulatory patient safety. And what we found, as you probably are not surprised, is that we really do not have a good handle on ambulatory patient safety problems. We don't have any good detection system for finding them. We don't have any good system for characterizing them. And we are only at the beginning of a journey to effectively implement and prevent them. And that despite all the adoption of electronic health records in the ambulatory space, we're really not using them effectively to build a safer system, if you will. And, you know, I think back to when my career started in infection control. I'm an infectious physician, and one of the very first outbreaks I had to investigate as an infection control infectious physician was an outbreak of Pseudomonas sepsis in an ambulatory gastroenterology center. And what we found is that ambulatory center hadn't effectively put in place a cleaning program to effectively sterilize the endoscopes between use, and so there was cross-contamination from patients around with Pseudomonas aeruginosa. So I think what we know is that as care increasingly moves into the ambulatory arena, it's an arena where we have much less oversight, much less supervision, and one where we were just at the beginning of learning how to do infection prevention and infection control oversight. And I think a key challenge of all this is we all know that more and more care is going to be provided on the ambulatory basis, and more care is going to be provided at the medical home. And I think those are huge challenges for us as we try to basically ensure safe care, especially around the area of infection control in those settings, and how we do that effectively. And also, it's clear that care will become clearly more segmented in the ambulatory environment and will move aggressively into procedural centers, some of these being sponsored by health systems, other things being sponsored by physicians. And how we effectively implement programs to detect safety problems and intervene in those centers, I think, will even be more challenging. Clearly, we have gotten pretty well at the hospital of using a variety of innovative methods around health information technology to build surveillance in the hospital setting, detect these problems, and then make sure all the common interventions are implemented to prevent things such as central line bloodstream infections, ventilator-associated pneumonia. What we have not done yet is a similar model in the ambulatory arena, in ambulatory centers, let alone in the medical home. And so I think that's our next big challenge. But what we do know from the studies we've done, that one of the biggest safety problems in the outpatient and medical home setting is infection. So much like in the hospital, it's a similar challenge. We just have a long way to go, I think, to innovate a system that detects and ensures common prevention strategies in that arena.
Well, David, thank you very much. And I just detected, and I don't know if anyone's having a polling problem putting free text entry at the end of the poll, but I am. And if we do have a problem, we'll send a survey out to you, and then Joe will come back to you on some of the answers of our polling questions because I think they're really important regarding the folks in our audience. I'm going to turn just to, as we finish up, to some of the questions. Chris Sarfati, I hope I'm not mispronouncing your name, is asking, I'm going to ask these two questions of you, Joe. Are there CDC materials specific to the outpatient dialysis facilities? And the second question is from Neil Aziaka. What is the CDC doing to extend the one and only campaign to the public to encourage public and patient empowerment? So the one question on dialysis facilities, and then the second question on getting the campaign out to consumers.
Okay, thanks, Chuck. Yeah, I'm happy to report that we do have CDC materials that are focused on infection prevention in the outpatient dialysis setting. We organized a successful prevention collaborative aimed at reducing bloodstream infection in dialysis clinics, and have those materials, and it's a really nice array of educational materials, checklists, and the like that are available on the CDC website. I'll make sure that as part of the follow-up from this webinar that we can distribute that link to you. And then as far as extending the one and only campaign to the public at large, that is something that we would very much like to do. As you can imagine, resource constraints affect, this activity as well, just as you're faced with those challenges. But we have recently tried our best to relaunch and reinvigorate the campaign, and I think reaching the patient population is very important. One thing, one way that one strategy that I see for doing that, again, is to emphasize that, we are all patients. So even as our messaging is perhaps primarily directed to the healthcare provider community, informing that provider community in a way that they become more informed healthcare consumers themselves, or thinking about their family members' care, their loved ones' care, their friends' care, their neighbors' care, is one way that we may achieve that. By raising awareness on the consumer side, I think that is one of the potential ways that we can sort of level that playing field in terms of having more uniform standards, if you will, in terms of things like accreditation, licensing, and just those basic expectations, the uptake of our CDC evidence-based guidelines for infection control, other relevant guidance.
Great. I want to finish on time, but I don't want to leave Elaine Flanagan out. I'm going to ask you a quick question, two quick questions, Joe. You've done a wonderful and magnificent job. Thanks, David Klassen. I know he's pulled in 15 different directions right now, but great comments. And Mary, you were awesome. But what I'm going to do is ask two questions of you, Joe, and one of them leads into Arlene so she can make a comment and then also close us. So Elaine Flanagan asks, cost is always an issue when we, in infection control, try to get departments to use single vials when possible. How can we get across the risk and cost of an HAI in that scenario? That's one, Joe. And the second is in the extended care in the elderly community of the nursing homes and the living supported living environment. That's an area where Arlene is a real expert. So we'd like to, in our pre-call, you addressed the fact that you are doing things there. So if you could answer Elaine's question about cost and single-use vials, and then secondly, comment on elder care in the nursing homes and those facilities, and then Arlene, go right after that so we finish on time, and you can make your comments as well as take a little longer to close us. Okay, Arlene? Go ahead, John.
Okay.
Okay, well, and I'll be brief. I think, the cost equation around the single-dose vials is something that you'll find that we try to address in that infographic, which I stepped you through. So I would look at that, this idea that infections can be costly, and so the focus on the short-term cost savings may be misplaced. And I would add to that, a reminder to, the hospital executive, the health system C-suite is concerned very much with maintaining, for example, accreditation status. And these are increasingly the types of things that are scrutinized as part of accreditation reviews. So those might be useful angles. And then regarding the long-term care environments, nursing homes, assisted living, and so on, we recognize that just as in the outpatient setting, there are many unmet needs regarding infection control. That is equally, sometimes more so true in the long-term care environment. I could, as part of the follow-up to the call, point people to the CDC webpage where we highlight the growing activities around infection prevention for long-term care.
Fantastic. Arlene, comments, and then we should close this, and then the speakers, if they could just stay on for a couple minutes so we can kind of make sure we do a process improvement loop, and we thank everybody for attending. Go ahead, Arlene.
Working in a nursing home for 11 years, I really see an issue, and it's leadership. Leadership is the most important thing, I think, in any facility. If you don't have strong leadership and those issues of infection control are not strong, you're not going to have a good environment. So leadership, and then the insistence that all staff are trained and retrained and take nothing less than doing it the right way. So leadership and staff training. I just want to comment that today's presentation was really good. I really learned a lot as a patient because with infection control, it is a team effort. And it doesn't hurt for a patient to be educated about the spread of infection. And we could keep our eyes open, and we could be proactive in our health care. And especially when a family member is sick, we could overlook their care too and have some knowledge on infection control. So today with healthcare providers using the best practices and best products for the best outcomes gives the patients the best chance for survival and not be impacted by something when it goes wrong. And healthcare is very complex, so there's different quality of leadership and different opinions, different solutions, and it's almost like getting together and finding that right solution and all working together to make a safer environment. Real quick, I just want to share, I read a quote yesterday, and it reminded me of patient safety, and it's from Dr. Martin Luther King. And the quote is, "The ultimate test of a man is not where he stands in moments of comfort and moments of convenience, but where he stands in moments of challenge and moments of controversy." And in our healthcare, there should always be a strong dedication to putting the patients first and their safety first. And when things go wrong, that dedication to their patient and their families should become even stronger. They shouldn't be abandoned. Sometimes that's the case. It's not right, but it is the case. So I believe together we could all make healthcare safer if we listen to our patients, because we do have a different perspective, and learn from mistakes and seek improvement. So those are my comments today, and I want to thank everybody for giving such a great presentation and for being on the webinar. Thank you.
Thank you all, and that closes our webinar, and God bless you all, and hope you can really leverage the work. Joe will look forward to getting the package and other links and information, and we want to thank Dave Klassen and Arlene and Mary and all of you for attending. And that ends our webinar. Thank you so much.